Okay, very good. So let's move on. So the next topic is one which is still actively discussed. How does risk status affect the choice of treatment? And I've used Joe's mSMART, which is one way of classifying, not everyone's way of classifying, but it's certainly a way to look at the different risk groups, high, intermediate, and standard risk. And most of the elements here are widely accepted. So the question is, with the increasing benefit with the new therapies, how do we view the use of these ever more powerful combinations as being appropriate for the different risk groups? An added element to that is if we choose to go for a deeper response, this will impact the availability of the drugs, the access, and also the cost of the drugs. And so does that figure in your decision making? So if we take the mSMART as a way of looking at the risk, so we have obviously the best risk and trisomies alone. That can be considered for RD therapy. Trisomies with other chromosome abnormalities, maybe use something a little bit more like CyBOR-D. 414, certainly a Velcade-containing regimen. And then high risk, VRD, or in more recent updates, even to consider possibly KRD. And so in the transplant setting, stem cell harvest. If you treat trisomies separately, maybe just RD. Stem cell harvest followed by consolidation and maintenance, and then likewise across the different options there with a little bit of fine-tuning. And so the question is, how do you approach the management of the risk status of the patient? Do you follow something like that, or what do you do right now, Mariby?
So we don't follow the SMART classification, sorry. But I think that to stratify or to identify the risk of each patient with newly diagnosed myeloma, we have to consider different aspects, like the age of the patients, the comorbidities, so
yes.
factors or characteristics related to the patient, and also different characteristics related to the disease. And so we consider, of course, cytogenetic abnormalities, and we do FISH analysis in selected plasma cells. And for us now, high risk means 414 translocation, 1416, deletion 17p, plus 1q with a question mark.
Right. So you would group the intermediate and high together, maybe, yes?
Yes, probably. And also, I would consider as a high risk another different features, such as the presence of plasma cells in peripheral blood or extramedullary disease. And I think that we have to consider all together as high risk, not only the presence of cytogenetic abnormalities. What is the problem from my point of view? That we have many new different combinations, and at the present time they are not able to completely overcome the poor prognosis of the presence of this high risk. So we are able to stratify very well each patient at the moment of diagnosis, but do we individualize the treatment according to the risk factor?
Right.
And at the end, we don't do many different approaches for one or another patients. We do some. For example, for patients with high-risk cytogenetic abnormalities, we usually do tandem autologous stem cell transplantation.
Okay.
This is based on a meta-analysis done by Michele Cavo, analyzing more than 2,000 European patients receiving bortezomib-based combination, followed by single or tandem autologous stem cell transplantation. And tandem transplant benefit to patients with high-risk cytogenetic abnormalities, and this is what we are doing.
Okay.
We close followed patients with, for example, extramedullary disease, and in addition with high-risk cytogenetic abnormalities, and if they early relapse after transplant, we immediately offer sometimes allogenic stem cell transplantation. And anyway, I think that probably the new combinations we have in the future they will be able to completely overcome the poor prognosis of high-risk cytogenetic abnormalities. And if we consider the data of the lenalidomide, dexamethasone plus something else combination that we have now at the moment of relapse, my message would be that high-risk patients have to receive 3 drug-based combination, including proteasome inhibitor, immunomodulatory drug, and steroids.
For sure, yeah. So maybe you could comment on this use of the stem cell transplant. I mean, there was a previous idea that stem cell transplant was not useful for high risk, for example. And even Bart Barlogie identified this as a subgroup where he was cautious.
Well, I think in the pre-novel agent era, Brian, it enriched for resistance because of alkylator resistance mechanisms and how that could magnify, for example, the effect or the clonal selection, arguably, for recognizing the complexity of genomic instability, magnify the impact of deletion 17 as a specific marker of that resistance pathway. I think, Brian, with novel agents, clear that that's not the case, that novel agents can overdrive, but I do think there is a relevance to induction and consolidation involving proteasome inhibition in overdriving that effect. Personally, I think at our center, we're relatively, we have a very similar approach to higher risk, that we will approach it aggressively, but we kind of have a somewhat different approach to concept of standard risk. Standard risk we don't think of as necessarily one that we reserve drugs from. We treat with triplets. The idea is what more do you do for the high risk rather than the more reductive approach of do you do less for the standard risk. So our view is standard risk is just as challenging in the longer term, arguably, in the sense of it not being curable. Higher risk is more likely to cause an early mortality, so therefore you up the ante.
So a simple way to look at this, you would basically use VRD for all of the patients at the beginning, is that right?
We would, Brian. We would do RVD across the board, and then we would tailor accordingly. And the question is, what would we add to that? Recognizing that obviously in Boston we have different access to drugs in ways than, for example, in Spain. And I think it drives to a very central issue of the evolving role of transplantation. Transplantation outside of the US is a standard of care for good reason, because the salvage options in ex-US countries are different. The reality is they are different. The availability of salvage strategies clearly has an impact on overall outcome. And so I think in the US we're in the position where, again, whilst the data clearly support the role of high-dose therapy in younger patients, no question about that with the PFS benefits seen. Having said that, there's no overall survival benefit. So therefore, we're not, for example, using tandem transplant in higher risk. We view that rather differently. Again, our own studies, the CTN trials, are still maturing in that regard. Our own, tandem versus single CTN experience was not in favor of the tandem. So do you see the differences that exist?
Yes. So
the only thing I might add to that, and actually I agree very much with what's being said. In fact, our now just recently updated criteria for what you presented is actually used VRD almost across the board. And has potentially suggested KRD or carfilzomib index in
the high risk group.
So I think what we're learning in general, as a simple principle, is that combining a proteasome inhibitor and an immune modulatory drug is better in myeloma, period. Yeah. It helps everybody, including the standard risk. But in that highest risk group, we're considering using the carfilzomib as potentially more potent. And the only last comment I'd make about it is what we're starting to appreciate, and I think we all would appreciate this, although MRD negativity, which we're going to talk about in a minute, or getting down to as tiny amount of disease as possible is very important. It's perhaps most important in the highest risk patient, because those patients' disease have that propensity to grow again. Whereas paradoxically, some people with standard risk disease may never get into an MRD but might do very well. So part of the rationale here was to say it's not just the initial more aggressive approach, it's that ongoing. I think that's one of the reasons why the tandem was helpful, was that it just helped get rid of, 2 scrubs of the mop in your floor will get more dirt out. So if you're scrubbing a second time, then you might get more dirt than you didn't get the first time. Sorry for the crude analogy. Not that I'm scrubbing any floors this afternoon, but if you need me to, I could. But but I think that principle of trying to get rid of the disease is important.
We have also to consider that if we offer the best option to a standard risk patient, probably they will be cured.
Well, and that's a challenge, and that I agree with you in principle. The problem is at that rate, and this may influence your final question here, is that are we doing that at greater cost? Not just financial cost, but does if we consider the best therapy, that extremely intense approach that we're giving to the high-risk patient, if we fully apply it to the standard risk patient in a total therapy-like approach, we're probably going to incur greater financial and perhaps more importantly, patient toxicity costs. And that's what we learned a little bit from total therapy. Is a lot of those patients, sadly, experienced long-term cytopenias, long-term fatigue, long-term neuropathy. And that's part of it. We don't want to be minimalistic by under-treating, but we also can be, I think, too aggressive and end up causing more toxicity.
Right.
That balance in the middle, I would pray to find it, but we're searching for it.
So I completely agree. I think, you use the analogy of scrubbing the floor an extra time. That's, of course, that's actually very good. I think the important point is that one has to be careful about the surround sound effect. And the issue there becomes exactly what you're saying, cumulative toxicities and the ability to bring to play other agents that will actually achieve the same thing but at far less acute and long-term toxicity.
Yes.
And in that regard, Brian, I was saying what I'm very struck by at this meeting and at ASCO is the impact of antibodies. Those are going to be game changers in this space.
Correct. And so that's what I wanted to close by asking you, Marie-V. So the double transplant approach, do you see quickly that there may be an idea to shift to some of those novel combinations?
Yes, of course. I think that in the future we will use the 3-drug-based combination plus the monoclonal antibody. And I think that this will be the new standard of care for newly diagnosed myeloma patients.
So do you already have some plan for this, a trial?
Yes, of course. We have
she always has a trial.
That's what I was thinking.
We have always in trials, but this is the best option to treat our patients.
Yes.
And in fact, to answer to scientific questions and to have access to all these new agents before to be approved. And of course, we are planning trials incorporating the monoclonal antibodies.
For sure. All right. And so we'll be picking up the idea of cost later. I think cost can be an issue here, but I think it's going to be much more of an issue when we're talking about the use of the novel agents as we move forward the course of the disease.